Good morning to the Polonovita and fellow students. Today, Raymond Chan, Reem Kaduri, Angeline Nathan, Ime Fernando, and myself, Harrison Fu of Group G, will be presenting a case on oral ulcerations. We will be covering the patient details, her presenting complaint, medical, dental, and social histories, and their relevance to the presenting complaint or management, description of the clinical photograph, list of differential diagnosis, special tests, and investigation, as well as management plans.
Mrs. HC is a 71-year-old female patient of unknown ethnicity who was referred to Dr. Polonowita. The case is regarding asymptomatic white lesions surrounding the lower left portion of her oral mucosa. It is also to be noted that the patient presents with corrugated nails and skin itchiness in both her arms and body. Mrs. HC is known to suffer from a heart condition, asthma, and gastric reflux. Further, in January 2010, the patient also underwent a hip replacement. Medications that Mrs. HC is currently taking include citalopram and Losec. She is also documented to have an allergy to penicillin and erythromycin. Now I would like to closely dissect the medical history to identify any possible and relevant oral health complications to our patient. The patient is known to have a heart condition. In patients suffering from heart disease, blood clots are significant as they can clog the arteries supplying the heart muscles and brain, increasing the risk of heart attack and stroke. A common solution to this problem is the prescription of aspirin, as it has been shown to reduce the risk of heart attack and stroke and reduce the short-term risk of death among people suffering from heart problems. It would need to be confirmed whether the patient was ever exposed to aspirin, as it is a common cause for chemical burns which may present as white lesions in the oral mucosa. Hypertension can increase the risk of heart failure and is often prescribed to patients with a heart condition. In such cases, it is commonplace for the patients to be placed on an antihypertensive medication to counteract these adverse effects. An associated issue, however, is the increased likelihood of lichenoid reactions, and it would again need to be confirmed whether Mrs. HC was treated with antihypertensives in the past. The patient also suffers from asthma and gastric reflux. Due to the anti-inflammatory and immunosuppressive effects of steroids, they are used in the management of bronchial asthma and oral mucosal diseases. The inhaled corticosteroid plays a central role in treating bronchial asthma. However, oral candidiasis is a complication often seen in patients inhaling corticosteroids and presents itself as a white thick coating on oral mucosa. Patients with gastric refluxes are seen to have palatal erosion of enamel due to the highly acidic environment in their mouth. Also, when gastric content reaches the throat, it leads to stimulation of the salivary glands and the consequent increased secretion of saliva. Such patients produce a large amount of saliva in order to minimize unpleasant, sour tasting, leading to hypersalivation. The patient is currently taking citalopram and Losec. Citalopram is an antidepressant in a group of drugs called selective serotonin reuptake inhibitors. The dental consequence of this drug includes xerostomia, progressive dental caries, and oral candidiasis due to hypersalivation. Losec is a selective and irreversible proton pump inhibitor. The key agent, omeprazole, suppresses gastric acid secretion by specific inhibition of the hydrogen potassium adenosine triphosphatase enzyme system found at the secretory surface of parietal cells. The inhibitory effect is dose-related, and omeprazole inhibits both basal and stimulated acid secretion irrespective of the stimulus. The patient is allergic to both penicillin and erythromycin. If the patient was to be exposed to these medications, then some of the more adverse reactions include nausea, vomiting, pruritus, urticaria, wheezing, laryngeal edema, and ultimately cardiovascular collapse may result. During the extraoral examination, there were no abnormalities detected in lymph nodes, TMJ, muscles of mastication, or the lips. However, patient reported that their skin felt itchy. Upon intraoral examination, there were 2 photos taken, and they will now be discussed by Harrison Fu.
This is an intraoral clinical photograph of Mrs. Taxi showing the lips with lipstick, maxillary and mandibular dentition, dorsal surface of the tongue, palatal region, and right buccal mucosa retracted with the mouth mirror. There is a small bruise on the maxillary lip, while the maxillary palate appears to be pale pink colored, and dorsal surface of the tongue appears to be more vascularized and red. There, there appears to be calculus and plaque deposits on the interproximal surfaces of the mandibular teeth. The teeth present on these photographs are maxillary right posterior teeth 16151413 and mandibular anterior teeth 333231 414243. 16 appears to be heavily restored with amalgam restoration. 15 appears to have a PFM crown, which is porcelain fused to metal. 41 is restored with composite resin restoration. Amalgam infraction can be observed generalized. There is also a small papule in the lower border of the maxillary lip. The right buccal mucosa appears to have a sparkled white and red lesion, approximately 10 millimeters in diameter. The lesion appears to be slightly raised. This is the second intraoral clinical photograph of Mrs. XC showing the lips with lipstick, mandibular dentition, lingua franum, left buccal vestibule, tongue, and floor of the mouth retracted with the mouth mirror. There is a small bruise on the maxillary lip, while lingua franum and dorsal surface of the tongue appears to be pale pink and well vascularized. The mandibular dentition appears to be heavily restored with amalgam and composite resin restorations, and there is a significant gingival recession present on the mandibular premolars. Left-hand side. The teeth present on these photographs are 37363534, 333231, 414243, 4445, 46, and 47. Enamel infraction can be observed generalized. Mandibular left side mucobuccal fold in 3-5 and 3-6 regions appears to be paler with small white maculae which do not appear to be raised. This is an orthopantomogram of metastasis showing the temporomandibular joint TMJ, maxillary sinuses, nasal septum, maxillary and mandibular dentition, inferior alveolar nerve, hyoid bone, and cervical spine. The position and the appearance of the TMJ appears to be normal. Slightly smaller maxillary sinus on the right hand side compared to the left, and normal appearance of the nasal septum can be observed. All the third molars are missing, with the remaining of the dentition heavily restored on the posterior teeth. There is a generalized alveolar bone loss horizontally. There is a small circular radial opacity on the distal root of 4-7 region. It could be some calcification, odontoma, or remnant of the 4-8. The cortical bone to the distal of 3-7 also appears to be more radial opaque, and 3-6 distal root appears to be shorter than that of 4-6. No other radiographic abnormality can be observed on this OPG.
Thanks, Harrison. As mentioned previously, the significant findings of Mrs. HC, which may be relevant towards our differential diagnosis, include she is age 71, female gender, asymptomatic white lesion, itchiness of the skin in the arms and body, unspecified heart condition, corrugated nails, and multiple amalgam restorations on the 3-6 and 3-7 adjacent to the mucosal lesion. The following is a list of differential diagnosis devised for Mrs. HC, and they include oral lichenoid contact lesion, discoid lupus erythematosus, oral lichen planus, carcinoma in situ, and oral mucosal squamous cell carcinoma, OMSCC. Oral lichenoid lesion is a reaction to either drugs, dental restorative materials such as amalgam, graft versus host disease, and other associated factors including dental tartar. A superficial examination of these lesions clinically and histologically often reveals many similarities with oral lichen planus. However, there are certain measures which can be performed to distinguish oral lichenoid lesion from a true lichen planus. Oral lichenoid lesions are more localized to areas of mucosa in direct contact with the restorations, or the onset of the lesion is concurrent with certain drugs and medication use. 2 theories have been proposed for the etiologies of these adverse reactions. The first is the electrochemical reaction, where there is an interaction between the dental materials, especially amalgam, and the oral fluids, resulting in structural degradation of the material and a release of byproducts that incite reactions to the oral mucosal tissues. The second is the mechanical force degradation, where masticatory forces causes wear and tear of dental materials and in an electrolytic oral fluid environment releases byproduct that similarly incites reactions to the oral mucosal tissues. The adverse reactions on the oral mucosal tissues can either be due to toxic or allergic. Lesions caused by the toxicity of the dental materials are a form of local inflammation induced by primary contact with chemicals and are not mediated by lymphocytes. On the other hand, allergic contact lesions represent a lymphocyte-mediated delayed type of hypersensitivity reaction that requires previous sensitization to the same chemical. The justifications that may support the findings of an oral lichenoid lesion for our patient include an asymptomatic unilateral white lesion localized to part of the mucosa in contact with the amalgam restorations of the 3-6 and 3-7 and skin itchiness. Lupus erythematosus is an autoimmune inflammatory connective tissue disease that commonly affects females above the age of 30. The exact cause of lupus erythematosus is unknown, but it appears to be linked with certain genes, environmental factors such as exposure to UV light, and chronic use of certain medications. There are two main forms, discoid and systemic. Typical lesions are white, often striate with irregular atrophic areas, but the lesions are often far less sharply defined than in lichen planus. In systemic lupus, arthralgia and rashes are commonly associated with multiple organ system involvement. On the other hand, discoid lupus does not involve multiple organ systems. However, the mucocutaneous lesions are indistinguishable clinically from systemic lupus. Of the two main forms, Mrs. HC is most likely to experience discoid lupus erythematosus, since she does not complain of joint pain or swelling, and history reveals no major systemic involvement, besides an unspecified heart problem, GI reflux, and asthma. According to the intraoral photos, the white unilateral asymptomatic lesion combined with a skin itchiness may be a possible manifestation of discoid lupus erythematosus. Oral lichen planus is a common chronic inflammatory autoimmune disease of the skin and mucous membranes that commonly affects females over the age of 40. It is characterized histologically by abnormal keratinization, basal cell degeneration, and a band-like infiltrate of chronic inflammatory cells predominantly lymphocytic in nature around the basement membrane region. The precise etiology of lichen planus remains unclear, however. It appears to be a T lymphocyte-mediated disorder with both CD4 and CD8 cells present, but the numbers of CD8 cells may rise during disease progression. Referring to the patient's histories, the justifications that may support the findings of oral lichen planus include an asymptomatic white lesion on the mucosal apical to the alveolar ridge of the 3-6 and 3-7, corrugated nails, and complaints of skin itchiness of the arms and bodies. Furthermore, our patient is female gender of age 71. Carcinoma in situ is a term used to describe the most severe dysplasia where the abnormality extends throughout the thickness of the epithelium but does not involve the underlying connective tissue. Common sites of oral epithelial dysplasia include the buccal mucosa, palate, floor of the mouth, and the mandibular mucosa and sulcus. Carcinoma in situ is recognizable by the presence of high-grade dysplasia in a biopsy. The best predictor of whether a carcinoma in situ is likely to evolve into squamous cell carcinoma is the degree of dysplasia. Risk factors for carcinoma in situ, which is relevant to a patient, include advanced age, female gender, and areas of rendering surrounding the white asymptomatic lesion. Furthermore, the asymptomatic lesion is in a common site for dysplastic changes to occur, which in this case requires further investigation to confirm diagnosis. Oral mucosal squamous cell carcinoma is a differential diagnosis that must be included for any white lesion of unclear etiology. It is the most common form of oral cancer in the head and neck region, accounting for 90% of all oral cancers. It is a type of oral cancer involving uncontrolled multiplications of cells within the epithelium. Common sites of OMSCC include the tongue, oral pharynx, lips, and floor of the mouth. The patient is unaware of the asymptomatic white lesion and does not complain of the lesion since it is asymptomatic. Nevertheless, a biopsy should be carried out if a definitive diagnosis cannot be made to rule out potential malignancies. Early diagnosis of oral carcinomas is essential since late-stage carcinomas have a very poor prognosis. I will now be passing on to Reem, who will discuss further with special tests and investigations.
Thanks, Ray. Special tests and investigations. To establish a provisional diagnosis, additional diagnostic testing is often required to supplement patient history and clinical observation, and also helps to discern between the various conditions which share common presenting features. Firstly, through careful visual assessment, one needs to establish whether the lower left mucobuccal lesion is presenting unilaterally and is isolated from the right lesion, or if the left lesion is an accompanying bilateral presentation of the right buccal lesion. In any case, both of these need to be palpated and assessed for tissue consistency, friability, and tenderness. White scar lesions can arise from mechanical trauma. Hence, it's necessary to question the patient about habits related to cheek biting or consumption of hot or acidic foods. Intraoral signs of parafunction or factitious injury, such as white, red, or black spots, or irregular inner cheek, need to be identified, and according to the clinical photos, there is suspected denuded area with a small black dot in the posterior region of the right buccal mucosa. For this patient, the oral presentation may be associated with underlying systemic condition, and so it's necessary to investigate these factors. The patient complains of itchy skin, and so if cutaneous lesions are identified, then a referral may be made to an allergy specialist or dermatologist for skin patch testing to identify the causative agent. Cutaneous lupus can present as thick red scaly rashes, and that can lead to scarring. Rash associated with lichen planus would be characterized by small, flat-topped polygonal bumps that grow together into rough scaly plaques. Contact allergens in dental restorative materials, such as amalgam on the 3,6 and 3,7, raises suspicion of lichenoid reaction, and so epicutaneous patch test of substances used in dental practice, as well as amalgam, can be performed to diagnose contact allergy. A full blood examination is needed to determine the presence of any deficiencies, assess the patient's immunological status, and potentially exclude or confirm the presence of immune-mediated disorders. If lupus is suspected, then preliminary complete blood cell count and testing for autoantibodies against double-stranded DNA would be required. Hematological testing can also help to detect viral infections, such as hepatitis C, which is a trigger for lichen planus. The clinical photos showed the white lesion to be subjacent to teeth that were heavily restored with amalgam. As such, mercury of dental material may have presented a systemic exposure, and so serum compatibility testing may be performed. While the diagnosis of a specific condition may be made by its clinical appearance, histologic examination of lesional tissue may be helpful when common characteristic features are observed or when trying to exclude malignancy. As a screening modality, brush biopsy is performed first and may help to identify the presence of hyperkeratotic lesions or to determine if a suspected lesion is precancerous. If findings are inconclusive or if atypical cells are detected, then an incisional biopsy may be undertaken for histopathological evaluation and to confirm the correct diagnostic finding. The biopsied lesion is examined microscopically, and in oral lichen planus, histological findings would indicate parakeratosis, fibrinogen deposits along the basement membrane, severe thinning of the epithelium, liquefaction of the basal cell layer, as well as band-like subepithelial infiltrate of T lymphocytes. In lupus, however, the inflammatory infiltrate would extend deeper into the underlying connective tissue, and this would show a perivascular pattern as well as basal cell vacuolization. When basal cells undergo dysplastic proliferation with cytological atopia, then carcinoma is considered. For the purpose of establishing a provisional diagnosis, our patient's presenting features are consistent with either a lichenoid-related process or an iatrogenic pathological process. However, for the purpose of comprehensive case analysis of all pertinent information obtained, Emile will now detail the management strategies for all the oral conditions listed in our differential diagnosis.
Thank you, Reem. My name is Emil. Today I'm talking about patient management. Lichen planus and lichenoid reaction management. The principal aims of lichen planus therapy are to resolve painful symptoms, oral mucosal lesions, reduce the risks of oral cancer, and to maintain a good oral health. Management of painful lesion due to lichen planus can be achieved by eliminating local exacerbating factors, treating any sharp teeth or broken restorations, scaling teeth to remove calculous deposits. Medication that causing the condition can be stopped, and replace them with alternatives medications to treat the underlying condition by consulting the physician. Oral lesion may respond to potent topical corticosteroid, and these should not be continued more than 3 weeks without a specialist referral. Widespread severe recalcitrant lesion can be managed with intralesional or stronger topical corticosteroids, topical tacrolimus, systemic corticosteroids, and topical systemic retinoids. Antihistamine medication can be prescribed to ease the itch, and emollients are often given to provide a moisture to the skin. Specialist referral may be indicated if there is a concern about malignancy, extraoral lesions, recalcitrant lesion, or there is a lesion which has not resolved after 3 weeks followed by about treatments. Moreover, follow-up dental visit at least in every 6 months is also essential. The management of discoid lupus erythematosus is aimed to improve the patient's oral health, appearance, and to control existing lesions, limit scarring, prevent development of further lesions, thereby begins with the use of sun protective and cosmetic measures. Standard medical therapy includes topical intralesional corticosteroid and antimalarials. As the alternative therapy, topical calcineural inhibitors for cutaneous DLE, topical retinoids, and topical imiquimod have shown some effectiveness in some patients. For recalcitrant disease, immunosuppressants and immune modulators should be considered. Consultation with a specialist such as rheumatologist, nephrologist, internist, ophthalmologist may helpful to obtain an optimum management outcome for the condition. Further, cutaneous manifestations of DLE can be managed by prescribing non-steroidal anti-inflammatory medications, low-potency immunosuppressants, and corticosteroids to the patient. Carcinoma in situ. If the biopsy shows a lesion to be carcinoma in situ, then the patient should refer to a cancer specialist so the condition can be managed adequately. Often the main treatment for carcinoma in situ is the complete surgical excision of the lesion. If the lesion is able to be removed completely, then the prognosis is good, although the patient is at increased risk of developing a new lesion at another site of oral mucosa. Therefore, monitoring, undertaking preventative measures, advices for healthy diet, and examining of oral tissues are recommended during the annual dental visits. Thank you. Now I'm going to hand over to Harrison. Oral squamous cell carcinoma. Multidisciplinary approach that includes surgery, oncologist, oral medicine, and dental staff usually offer the best outcome for the condition. Oral squamous cell carcinoma currently is treated largely by surgery and irradiation using the TNM system. Photodynamic and chemotherapy have occasional applications, and there is an increased use of target therapy. Radiotherapy can be performed on early and locally advanced OSCC, alone or more frequent with surgery and chemotherapy. Prevention and treatment of oral complications whenever possible are important and should be performed by an oncologic team, including a dental practitioner and an oral hygienist. Extremely important, but often overlooked, is the need of psychological counseling. The patient must be counseled carefully to ensure that they can adjust at least partially to the complications of the cancer therapy. Pharmacotherapy for oral squamous cell carcinoma is to reduce morbidity associated with secondary infections and to prevent complications. Therefore, antiviral, antibacterial, antifungal agents can be prescribed to the patient. Routine follow-ups visit can be schedules for oral squamous cell carcinoma patients where observation of treatment progress can be undertaken and instruction can be provided to the patient to minimize habits of tobacco and alcohol use.
So, in conclusion, on the basis of our analysis and discussion of patient presentation and clinical observation, it is plausible to suggest that patient Mrs. HC is presented with bilateral lichen planus. Thank you very much, everyone.